Thanks everyone for joining in their busy schedule. Well, today I will discuss specifically regarding the role of olaparib inhibiting HRR in metastatic castrate-resistant prostate cancer. Quite an extensive presentation and excellent slides to understand how the clinical trial is designed and what is its practical applicability. So, uh, okay, so I will start initially with the introduction to prostate cancer, and then we will understand what is the molecular heterogeneity, and then what is the role of a PARP inhibitor, and what are its practical implications, and what are the guideline recommendations. So, we all know prostate cancer is 16th in its incidence in India. So the incidence is less than that of the other countries because we don't have a routine PSA screening. So the incidence also depends on what type of screening we have in our country. So we're doing less tests. That's the reason why it is lesser. The incidence is lesser when compared to the West. Very importantly, you can see that whatever metastatic prostate cancer we have, ultimately they become castrate resistant. And
जल्दी करना है
Able, you can mute the other members. You are a host. Yeah. So ultimately, whatever prostate cancer we have an initial castrate sensitive period followed by a castrate resistant period. Ultimately, the overall survival of a castrate resistant prostate cancer is around 1 to 2 years with whatever best treatment right now we have. Maximum 2 to 3 years is what is the range right now we have. So there is an unmet need of improving outcomes in a castrate-resistant prostate cancer. So these are the incidences across the globe. You can see India has the one of the lightest shades. That doesn't mean that the incidence is less. It is that we don't have an effective screening program. The recommendation for prostate cancer screening or testing vary by country, and this may be the possible reason for differences in incidence of prostate cancer. So, so what are the risk factors of developing prostate cancer? Extremely important is the age. You can see that peak age is between 65 to 74 years. So after 74, the incidence reduces, whereas that peak age of 64 to 75, or even 55 to 75, you can say, that is the peak age. And now there is a tendency for younger age to get prostate cancer. So for whatever reasons, and there has been a 2% annual percentage change in global incidence in the age of 15 to 39 years. So you can see younger men having prostate cancer right now. So the moment younger men have prostate cancer, then overall survival becomes extremely important endpoint. So it is not the endpoint doesn't end at palliation. We must also look into improving overall survival. So that therefore it is an unmet need to improve outcomes in a castrate-resistant prostate cancer. So then, so this is the natural history of prostate cancer. We have initially a localized disease, which usually is treated with radical intent with surgery or radiation, and then there is a non-castrate or biochemical failure, and then we have a non-metastatic CRPC. Then we have a metastatic hormone-sensitive prostate cancer, and then you can see the rightmost column. We have a metastatic castrate-resistant prostate cancer. So localized disease, castrate sensitive disease, then metastatic hormone sensitive, and then we have metastatic castrate resistant prostate cancer. So we have to focus in the last particular column, where ultimately majority of metastatic prostate cancer will develop a castrate resistance at some point. And I said the survival of these is around 1 to 3 years. That is the range we have. So that mCRPC uh, can have an asymptomatic disease or a symptomatic disease progressed on chemotherapy or can be chemo negative. So this is our focus today, and there is an ongoing need to improve outcomes in mCRPC patients. For the simple reason that the incidence is high, majority of the metastatic prostate cancer will become castrate resistant at some point of time, and the overall, in spite of there being new medicines, novel androgen, new anti-androgens we have like enzalutamide, apalutamide, or you have abiraterone. In spite of that, the overall survival is within 3 years. Therefore, there is an unmet need to improve overall survival in these set of patients. So, what is this molecular heterogeneity? So, we have come far beyond histology, adenocarcinoma, neuroendocrine tumor, or just a Gleason score or a stage. This is no more enough to understand an advanced prostate cancer. So, we need to biologically understand prostate. So, we have done well as far as breast cancer is concerned, where we have hormone positive, HER2 positive. Similarly, we have lung cancer where it is completely heterogeneous. So now we have a molecular heterogeneity even in prostate cancer. So you can see approximately 90% of mCRPC have genomically aberrant pathways, and you can see androgen receptor, PI3K, and DDR is a defect in DNA repair, and Wnt and cell cycle signaling pathway. You can see that PIK3 is there in nearly 50%, and androgen receptor aberration is there in 71%, Wnt pathway in small 18%, and you have this DNA repair present in nearly 23% patients. One fourth of them have this DNA repair issue. So it is that subgroup which is important because it is this is the biomarker. If I can find out prostate cancer cells which have a deficient DNA repair mechanism by what we call as if I do a BRCA test or I do an ATM testing or what we call as a HRR testing, which I'll be saying. And if I can pick up these cancer cells which have a deficient DNA repair as a biomarker, and if I can expose these patients to PARP inhibitors, then I will have an overall survival. Therefore, prostate cancer is not a homogeneous disease. It is a heterogeneous disease with multiple pathways being active, PIK3 being the majority, androgen being in higher number. However, in nearly one fourth, 25% of them, we have a deficient DNA repair, and we need to pick these because we have an active drug that improves outcomes in these nearly one fourth of patients. So these are the types of repair we have. So we have, as far as DNA repair is concerned, we have base excision repair. For example, if there is single strand DNA break, so base excision repair is there. PARP is good enough for a single stranded repair. And similarly, we have bulky adducts. This requires a nucleotide excision repair. And then we have a mismatch repair. So very important is a double stranded DNA break. So to repair a double stranded DNA, you require these ATM gene, BRCA, PAL-B2, and RAD5, and so on. So you need these genes to be intact to have a proper double-stranded DNA repair. So if I have, if I am deficient with these double-stranded DNA break repair genes, supposing we have a BRCA deficiency, then the BRCA deficient cell will not be able to have a double-stranded DNA repair. But the single strand DNA repair mechanism, that is PARP, is intact in these cells. So normally what happens is during cell repair, whenever there is any double stranded DNA break for whatever reasons, the cell has the mechanism using these BRCA and all to repair a double stranded DNA break. Otherwise, if they cannot repair, then the cell is going to die. So therefore, to have a proper repair mechanism of dsDNA, double stranded break, you need BRCA to be intact. So, but if I have absence of BRCA, but if I have a PARP enzyme active, This PARP enzyme does only a partial repair. It does a single stranded repair. It doesn't do a double stranded repair. So what happens is if BRCA is absent and PARP is present, then the double stranded DNA break which is there is partially repaired by PARP. So this partially repaired cell will survive, and this becomes cancerous. So you have a defective cell which is incompletely repaired by PARP surviving, and this is a defective cell. So therefore, if I can inhibit the PARP when the dsDNA repair mechanism is not there, that cell is going to die. So this is what is called as synthetic lethality. So there is always a particular gene deficient, and the other gene, the other enzyme that is PARP enzyme, which is trying to repair, is causing more damage because it is causing incomplete repair. So therefore, if I inhibit even this PARP enzyme, then the cell goes in for apoptosis. So therefore, this is what is called a synthetic lethality. So HRR pathway is important for dsDNA breakage, repair, and if this is absent, then inhibiting PARP causes cancer cell lysis and improves outcomes. So these are the genes. So I said nearly 25% of them have these problems. And if you look finely into which are the genes that contribute to the HRR pathway, so very importantly here we have both germline and somatic equally important. In an ovarian cancer, somatic contributes a very small percentage of 2% or uh, around 2 to 3% and not more than that. Whereas in a prostate cancer, you can see 50% contribution is from somatic. Therefore, if I, in a prostate cancer patient, if I say that I will get away by not doing a somatic BRCA, I will do only a germline BRCA, I will not be picking nearly 50% of patients. So the way to go in a prostate cancer is not germline BRCA alone. I must be doing a somatic HRR. I will pick up not only BRCA, BRCA2 is the most predominant in prostate cancer. We also have BRCA1, we have ATM gene, we have CHEK2. So these are the four names that we need to remember. The take home message is we cannot get away not by doing a somatic HRR or somatic BRCA. I must uh, do a tissue or a somatic BRCA. If I do only germline BRCA, I'll be missing more than 50% of patients who are going to be eligible for olaparib therapy. So that is the take home message. BRCA, ATM, CHEK2. These are the important pathways that we need to pick up. BRCA2 is the most common. Somatic is the way to go. Germline, if I'm doing alone, then I'll be missing more than 50% of patients eligible for olaparib therapy. So these are the recommendations from NCCN, ESMO, and the Philadelphia Consensus Conference 2017. In cases of advanced prostate cancer, especially CRPC, we must consider HRR testing. ESMO does not provide any such recommendations, whereas this Philadelphia consensus says that at least a BRCA2 has to be done in the set of patients. So NCCN says advanced prostate cancer, we must do HRR pathway. We must look into the deficient DNA repair mechanism so that they become eligible for targeted therapy. So, what are the key takeaways we understood during our previous talk? Prostate cancer, metastatic prostate cancer, if prostate sensitive now, almost everybody will become castrate resistant at some point. The moment castration resistance is attained, the median survival is less than 3 years. And metastatic prostate cancer is no more a homogeneous disease, it is a genetically a heterogeneous disease. And this DNA repair deficiency as a biomarker is present in nearly 25% of patients. And if I can use a PARP inhibitor in this subgroup, I can improve outcomes. And DNA repair gene aberrations are enriched in patients with locoregional biochemical recurrent and metastatic prostate cancer patients. So the way to go is a somatic BRCA and not just a germline BRCA. That is another take-home message. So let us go into the clinical details of PARP inhibitors in prostate cancer. Let us go into the profound trial. So this is the background. A similar thing, the background is CRPC is lethal, survival less than 3 years, and then up to 30% patients have this HRR pathway deficiency. PARP inhibitors have shown improved outcomes, and let us see what is this clinical efficacy. This is the profound trial, which is the landmark registration trial. This is the only first, the largest phase 3 randomized controlled trial of olaparib versus new hormonal agents in patients with HRR mutated castrate resistant prostate cancer. So, what all I must have? I must have a metastasis, number one. The patient should have a documented castrate resistance, that is low testosterone levels, still the patient is progressing. And number three, the patient should have failed at least one prior therapy. Maybe they would have received taxane or not, they should have failed at least one newer hormonal agent. They must have failed. Either they must have failed abiraterone or enzalutamide, and they may or may not have been exposed with docetaxel or chemotherapy in the HSP setting or in the CRPC setting. So compulsorily, they must have been exposed with one uh, prior treatment with a newer hormonal agent. These are the eligibility criteria, and they must have had an HRR deficiency. So qualifying HRR mutation in tumor tissue is important. I will show you what are the genes they have looked into, but what you must remember is CRPC, metastatic, at least one new hormonal agent. Docetaxel may or may not be exposed before. So if you look into there is cohort A and cohort B. So they had BRCA 1 and 2 and ATM in cohort A, whereas cohort B had other genes like RAD5. I'll be showing those rarer mutations, which is non-BRCA, non-ATM. So this is the randomization. Olaparib 300 milligram twice a day versus treatment of physician's choice 2:1 randomization. Here, physician's choice was restricted. They did not allow use of taxane here. If a patient had progressed on a newer hormonal agent, for example, patient received abiraterone in the HSPC setting, and the patient progressed to CRPC. The trial does not allow the physician to choose docetaxel. It allows only to choose a newer hormonal agent like enzalutamide. This is a drawback of the trial where the physician's choice is restricted by using a new hormonal agent and cannot choose chemotherapy. Or for example, a patient is there who had a metastatic castrate sensitive prostate cancer, used docetaxel, then developed CRPC, then used abiraterone. Then if a patient progresses on abiraterone, I'll be looking for giving him cabazitaxel and not enzalutamide. So looks like in this particular trial, one of the criticism is that the treatment of physician's choice is not clinically appropriate because the physician is restricted from using an active chemotherapy drug like docetaxel or cabazitaxel. This is one of the criticisms of the trial. Having said that, if I am taking oral drug into consideration, it's olaparib versus another newer hormonal agent. So we know that if a patient has progressed on one new hormonal agent, it is unlikely another new hormonal agent will benefit. But still, they took this is the randomization arm. So it was stratified by prior taxane exposure and whether measurable disease was present or not in the baseline. So this was the primary endpoints, that is radiological PFS, and the secondary endpoints were response rates, radiological PFS by independent review committee, and time to pain progression, overall survival, safety and tolerability. These are the cohort A and the cohort B genes. The BRCA1, BRCA2, and ATM are in the cohort A, whereas in the cohort B, you have all these rare genes, BARD, CHEK, PALB2, RAD5, and so on. So this is based on the Foundation 1 testing, 15 genes which they picked up. So these are the baseline characteristics, nothing much important in this, that all the baseline characteristics were well matched. You can see a bit of more visceral mets were there in the treatment of physician's choice arm. So a bit of difficult to treat patients were there in the control arm and not in the test arm. This is one we can note. And then ATM deletions were quite higher here. And then these are the baseline PSA levels, a little bit higher in the physician's choice arm. And then measurable disease was well balanced. And then neohormonal. So what you can see here is regarding the prior taxane therapy. It was given, prior taxane was used nearly in 65% patients. Did have previous docetaxel or cabazitaxel based therapy. So 65% patients had previous use of taxanes. And then enzalutamide only before was in 40%, abiraterone only was in 38%, whereas nearly 20% or 19% patients had both abiraterone and enzalutamide exposure before. So these are important. 20% had both being exposed, and 65% had previous taxane exposure. So these were the most prevalent genes. BRCA2 was the most prevalent among all the subgroups. And the primary endpoint of the PROFOUND trial was the radiological progression-free survival, and the study met its primary endpoint. The difference in PFS was 7.3 versus 3.5 months, almost more than doubling of the progression-free survival. So the hazard ratio is 0.34 with a statistically significant p-value. The study met its primary endpoint. This is in the cohort A population. And if you look into the forest plot, there was no such subgroup that benefited preferentially. All the subgroups, irrespective of PSA, ethnicity, ECOG performance status given 2, visceral mets or bone-only mets, everybody benefited. And very importantly, whether there was prior taxane use or not, that did not matter, everybody benefited. So these are the response rates. You can see statistically significant response rates in the cohort A in the olaparib arm versus the new hormonal therapy arm. So the p-value is statistically significant. The odds is 20.86. Good response rates. And this is had a overall survival benefit also. You can see the tendency towards overall survival, hazard ratio being 0.64 with a p-value. And remember, crossover was allowed in this particular trial. So in spite of crossover, there was a tendency towards overall survival, 18 versus 15 months. Differential of over 3 months were seen between the arms in terms of overall survival. This is in the cohort A plus B. This is the radiological PFS. The benefit is little lesser than the cohort A alone, however, statistically significant. Again, the forest plot saying that whether I have common mutations or I have rare mutations combined, all subgroups benefited with olaparib. Response rates were better, and the overall survival also was 17 versus 14 months if I included the intent to treat population, in spite of 80% of patients crossing over to the olaparib arm. This is another endpoint which we all look into. The median time to pain progression was statistically better. You can see the time did not reach in the olaparib arm when compared to the physician's choice. Hazard ratio was 0.44. This says that there is symptomatic benefit if I am using olaparib in those patients who have HRR deficiency. This is both A plus B, whether I used rare mutations or I had commoner mutations in both the subgroups, median time to pain progression was statistically significant. So this is the pre-specified sensitivity analysis of radiological PFS, and in the BICR in both cohort A plus B, and B. So very importantly, BRCA and ATM are the most sensitive. Hazard ratio is 0.24 in terms of radiological PFS, whereas if I have B alone, the hazard ratio is 0.6. The difference is there, but not to the extent of A versus olaparib versus physician choice. So if I have commoner mutations like BRCA and ATM, I have a big yes, I must use. The the benefit is very significant, hazard ratio is 0.24. Whereas if I have rarer mutations like PAL-B2 or RAT15, even there the benefit is there, but not to the extent of the commoner or BRCA2 mutation. So then these are the radiological PFS based upon each gene alone. Very importantly, you can look into the most important is the BRCA2 mutation, which is the most sensitive. So this and there was always a criticism about prior taxane use. So here is a curve whether taxane was used before or not. The hazard ratios were better. You can see the hazard ratios are far much better if there was a prior taxane use. In terms of radiological PFS, whether cohort A alone or A plus B, in both, irrespective of prior taxane use, there was a significant benefit. And even the OS benefit was greater for olaparib versus treatment of physician's choice, irrespective of taxane use. You can see the hazard ratios in terms of zero 0.5, 0.8, and so on. So the duration, because these patients in the olaparib arm did not progress, they were on a longer time on olaparib. Therefore, there were increased incidence of toxicities. You can note important toxicities very being the hematological toxicities, anemia, and then we have nausea, fatigue and asthenia, loss of appetite, diarrhea. These are the most common. You can note nearly 50% of them had anemia, any grade of anemia, and grade 3 or more anemia was there nearly 20% patients. Fatigue and asthenia was in 40%, and then nausea in 40%, and diarrhea in around 30% patients. So the adverse events were more common, or they were commoner than the control arm, the treatment of physicians, because they were on olaparib for a longer period of time, and there were no reports of MDS or AML. So, of special interest, we have hematological toxicity. It's a recognized complication of olaparib because it affects the marrow cell lines also. It inhibits proliferation, and that's the reason why you have anemia, neutropenia, and thrombocytopenia being there. So fatal pneumonitis also seen, but was not accountable due to olaparib. And however, there was no MDS AML in this particular trial attributed to olaparib. So what are the key takeaways? The PROFOUND trial is the largest and the only phase 3 randomized trial of a PARP inhibitor, olaparib, versus neohormonal agent. The study met its primary endpoint in terms of improvement in almost more than doubling of radiological progression-free survival, and not only commoner genes like BRCA and ATM, but also if you took uncommon genes, the benefit was maintained, and the safety was reasonably well. A bit of hematological toxicities. Other than that, it was fairly well tolerated. The only criticism of the trial is that the treatment of physician's choice did not allow them to use chemotherapy. They were restricted to use a new hormonal agent in spite of the patients progressing on a new hormonal agent before. So then coming on to the what are the diagnostic changes? So these are important. Something more on how easy or how difficult it is to do HRR testing. You can see the archival tissue. So the majority of samples assessed in the trial were from archival core biopsy from the primary tumor. Prostate archival specimen is what they used in majority. So you can see importantly in a clinical trial setting also, if I have to do a somatic HRR mutation with the best procedure I have, we can see nearly 30% failure rate, and the failure rate is mainly because of lack of DNA extraction problems, and so on. So this is the clinical trial failure rate of having a somatic HRR mutation. And in clinical practice, there will be a little more than this. So the test success rates, so if I have to do a BRCA, there is always a question. If I have to do a HRR deficiency uh, 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 investigation, the best way to go is on a newly biopsied sample, and the best is on the metastatic. So new sample is better than the archival. Metastatic sample is better than the primary prostate. So archival primary prostate has the least yield and the failure rate is nearly 50%. Therefore, whenever I want to improve my or improve my pickup on HRR in prostate cancer, I must try and do a new biopsy, and the biopsy should be from the metastatic site whenever feasible, because here it is around 65%, and it is around 50% if I am doing on the primary prostate. So the majority of samples were collected from prostate over a broad period of time, less than 1 year to more than 10 years. So this is the HRR mutation prevalence in screen population, which I already discussed, and look at the prevalence of HRR alterations in primary and metastatic. In primary, it is around 27%, in metastatic plus 4%, 31%. So if I have to choose, I will do a new biopsy and I'll do a biopsy from the metastatic site and not from the primary. So these are the things. What we have come up is just a combination of tests is more important, like a liquid and a solid. But if I am using a solid, very important is I must use a 10% neutral formalin buffer in 8 to 10 hours, 8 to 24 hours, and I must properly fix it, what we call as the FFPE, fresh formalin fixed paraffin embedded specimen. And very important is DNA extraction. The pathologist must determine whether the specimen contains sufficient neoplastic material, that is more than 20%, and enough tumor cells, that is 1,000, for a test to be successfully conducted. More than 20% and at least 1,000 tumor cells needs to be there, and this assessment has to be done. This is the quality picture. So, what was the test failure is a possibility, and why does it happen? Pathology failure, there is no adequate tissue content in 20% around, and nearly 40% DNA extraction failure. Tissue is there, the DNA is denatured, I am not able to extract. And the third possibility is failure after DNA extraction. The quantity is there, but the quality of DNA is not adequate to do these sensitive HRR testing, which is quite sophisticated. So current practice is to assess HRR. I can do a blood test. I can do circulating tumor DNA or circulating tumor cells or tissue testing. So the most commonly performed is blood testing. But if I do only germline testing, we must remember that we are missing nearly 50% of patients, because somatic testing is the way to go as far as CRPC and HRR is concerned. So, circulating tumor DNA in prostate cancer. So you can see, yes, circulating tumor DNA is the way to go, but not the standard of care. There has been a concordance between tissue and circulating tumor DNA, and is still unpublished, but data from other studies have shown acceptable concordance between ctDNA and tissue. This is another way to go. So this is a so instead of using only somatic BRCA testing, I must be using both. I must use a circulating tumor DNA, and if it is negative, I must have a rebiopsy to augment the number of patients I pick up. So this is a good way to go. You can see tissue as the primary modality. If tissue testing is successful, happy with it, I can make a clinical decision. If tissue testing is not successful, then I must do a plasma circulating tumor DNA and also a blood germline testing. So what are the key takeaways I can have? Majority of samples assessed in profound
पढ़ने का लोग
study.
इसे पढ़ने का था
Shoaibal, can you mute other participants? Okay. So what are the key takeaways we had from these? In this trial, we used uh, the archival specimen in majority of patients. However, archival tissue resulted in nearly 30% failure rates, and retrieval of FFP tissue block from tissue bank or archive may be a challenge. Test success rates were higher in newly biopsied samples and biopsy from metastatic sites. Majority of samples were collected from prostate tissue. However, the testing success rate, if I collected from prostate, was around 56% only. The quality of NGS HRR mutation testing relies on the tissue fixation, processing, storage, DNA isolation, and the NGS method I use. So, to coming on to the conclusion part, what are the final take-home messages? Yes, we have a drug, olaparib. For the first time in prostate cancer, we have a biomarker-based treatment which has shown a statistically significant radiological progression-free survival. And the other endpoints like response rates, time to pain progression, overall survival are also improved, not only with commoner mutations like BRCA and ATM, but also uncommon mutations also have shown benefit. Irrespective of whether taxanes were used before or not, both the cohorts did benefit equally and significantly with olaparib, and it was safer enough except a bit of hematological toxicities of anemia. However, no MDS were reported in this particular trial. Tissue success rates in this trial, nearly 30% failure rates were there in the clinical trial. However, it can be improved by doing a new biopsy, uh, by doing a biopsy from metastatic site. And if that is not possible, then I can do a circulating tumor DNA sampling or even a germline BRCA. So a germline BRCA, if I do in prostate cancer, it's not sufficient. I'll be missing more than 50% of patients will be eligible for olaparib. So Profound trial is the first positive biomarker selected phase 3 study evaluating a targeted therapy in men with metastatic CRPC, and olaparib is the only PARP inhibitor to improve overall survival versus neohormonal agent in HRR mutant or deficient CRPC, highlighting the importance of genomic testing in this population. So then coming on to final guideline recommendations, you can see here NCCN consider inclusion of olaparib in men who have HRR mutation and have progressed on prior treatment with enzalutamide, NRR, abiraterone, regardless of prior docetaxel therapy. So with this, I would come to a conclusion saying that yes, Profound trial is an excellent trial. For the first time, we have a biomarker being there, uh, uh, the HRR for selecting out CRPC patients for exposing them to olaparib. The Profound trial met its primary endpoint of progression-free survival and the other endpoints like response rate and overall survival. However, the only criticism of the trial was that the control arm was restricted to use a newer hormonal agent in spite of these patients progressing on a newer hormonal agent before. So if uh, the control arm or the treatment of physician's choice were free to choose a cabazitaxel or another taxane, the results would have had a greater weightage. However, CRPC survival is around 1 to 3 years. It's an unmet need, and we must always look at presence of HRR by doing a somatic HRR testing. And if it is present, we must try and expose these patients to olaparib, 300 milligram twice a day, because it improves radiological PFS, response rates, and overall survival in spite of crossover. So I would thank everyone for their patient listening, and I would uh, be back to Shaibul for further
Sir,
proceedings. Yeah.